Doug Brown. I'm the pharmacy intern reaching out to discuss patient Thomas Jordan, a 63-year-old African-American male, and reconciling his medication list and a few drug interactions.
Hi, Doug Brown. I'm also Dr. Doug Brown. I'm happy to listen.
Patient came to the clinic with a chief complaint of confusion about what medication he should be taking. He was discharged from the hospital 1 week ago with a new diagnosis of HFpEF. He reports feeling better today. He has a past medical history of hypertension, recurrent DVT, hyperlipidemia, and osteoarthritis.
So at discharge, the patient was prescribed lisinopril 10 milligram daily, atorvastatin 40 milligram daily, Eliquis 5 milligram twice daily, furosemide 40 milligrams twice daily, potassium chloride 20 milliequivalents once daily, and lastly the metoprolol tartrate, which was prescribed 25 milligram twice daily. The patient reports that he's currently taking lisinopril 10 milligram daily, amlodipine 10 milligram daily, atorvastatin 40 milligram daily, Eliquis 5 milligram twice a day, furosemide 40 milligram twice a day, and lastly the metoprolol tartrate 25 milligram twice daily. Oh, and then also naproxen 220 milligram twice daily. The patient has no known drug allergies. His blood pressure today is 119/72, and his pulse is 61 beats per minute. The patient weighs 180 pounds, and he is 5 foot 6 inches tall. His echocardiogram showed that his LVEF of 55 to 60%, moderate left ventricular hypertrophy, grade 1 diastolic dysfunction, and mild tricuspid regurgitation. His CMP is within normal limits except for slightly elevated glucose, which was 102 milligrams per deciliter.
There are some risk differences between the patient's reported medication list and the medications given at discharge. The patient is still taking amlodipine, which should have been discontinued upon discharge. Additionally, the patient is not taking their potassium chloride, which was also prescribed at discharge. A drug interaction checker tool on Lexidrug and Micromedics show drug-drug interactions between naproxen, lisinopril, amlodipine, metoprolol, and furosemide, as naproxen can increase blood pressure as well as another interaction with Eliquis due to increased risk of bleeding. Additionally, per the 2022 AHA-ACC heart failure guidelines, an SGLT2 inhibitor has a 2A recommendation for reducing HFpEF hospitalizations. The goal of therapy is to optimize the patient's medication regimen by ensuring its safety and efficacy.
Based on our assessment, we recommend 1. Discontinuing amlodipine 10 milligrams once daily and starting the potassium chloride 20 milliequivalent tablets by mouth once daily as prescribed at discharge. The potassium tablets should be continued as long as the patient is on furosemide to avoid the risk of hypokalemia. 2. We recommend discontinuing the naproxen and recommending an alternative pain management medication such as acetaminophen to avoid lowering the efficacy of their antihypertensives and reduce bleeding risk with Eliquis. 3. We would recommend considering the addition of Farxiga 10 milligram tablets by mouth once daily to the patient's medication regimen to reduce the risk of heart failure hospitalizations long term. If cost is a concern, pharmacy can help the patient buying discount cards to reduce the burden of this medication. A follow-up appointment should be scheduled in 4 weeks to reassess medication adherence and monitor volume status, blood pressure, renal function, electrolytes, and signs of bleeding. The patient should monitor for signs and symptoms of hypoglycemia and volume depletion if started on Farxiga. Consider a pharmacist-led medication therapy session to further educate the patient on their heart failure medications and address any remaining confusions at this time. If the patient experiences any signs of acute decompensated heart failure, such as gaining 3 pounds in a day or more than 5 pounds in 1 week, severe fatigue, or altered mental status, they should contact their physician right away.
Thank you, Doug Brown. Thank you for the recommendation. We'll look into that.